Okay, we're starting recording. If there's no further questions. So schizophrenia and other psychotic disorders. Oh, by the way, Carl Roston, the suicide prevention coordinator for the state of Montana, is going to be giving chiming in on the QPR for the week that we cover psychiatric emergencies. So that'll be good. That'll be good. Schizophrenia spectrum and other psychotic disorders. So schizophrenia, you can read that there, but basically you have delusions, okay, hallucinations, and you have to have two or more of these actually, but oftentimes you'll have most all of them, frankly. So delusions, hallucinations, disorders of thinking. Then the social occupation impairment, social and occupational impairment. Oh, and the negative symptoms. We're going to talk about the difference of all those things here in just not too long, of course. I'm trying to get the right lighting here where I am, excuse me. Yeah, it doesn't work. So, and it has to have a certain duration. The duration of, I think it's over 6 months. Yep. Depressive schizoaffective disorder and bipolar disorder psychotic features have been ruled out, and we'll talk about those in a little bit as well. So these other things are also just ruled out. So key dimension is the hallucinations. I'm gonna get this up here. So it can be in any sensory modality. This is the psychotic dimension. They're talked about dimensions. There's psychoses and positive and negative symptoms. Okay, so we'll talk about what those are. There's the disorganization dimension, negative dimension, etc. So we'll cover all those. It can be in any sensory modality. The psychotic symptoms, the hallucinations, usually it's auditory, but also with visual hallucinations are not too uncommon either. So those are the two most common ones. You can have other ones like olfactory and gustation, tactile, but in general, those occur less often. They're not hypnagogic and hypnopompic hallucinations. Hypnagogic is when you go to sleep, and hypnopompic is when you wake up. And most people probably had those, right? Where you just fallen asleep and you think you hear somebody, or you think you see someone. That's another kind of common one. So those are not it. It's not that. That's a common hallucination. And here's the different types of delusions. The other thing you could have actually for without the textbook is just my lecture, because I'll cover a lot of that in the lecture. So persecutory, it's pretty easy. Some people they're after him. This FBI, different kinds of churches, that sort of idea. Referential. This is where they think people, it refers to them, like the news or songs or whatever, is speaking particularly to the person with schizophrenia. Grandiose, I think the next great person, perhaps they're the next savior, that kind of idea. Erotomaniac, that's where they have feelings that someone's in love with them from afar, usually a famous person of some sort or another. Nihilistic, that one is dead or dying. There's people have a sense that they're all dead on the inside, that they're rotted on the inside. It's kind of a nihilistic thing, which is similar to what somatic in this way, but it's a little bit more death as opposed to rotting. It's kind of a subtle distinction, though. Probably don't need to. In sexual behavior is commonly known. Everybody's watching you. In common one, it's actually people think you think you're a prostitute. People think you are. That's actually pretty common. And finally, religious. They sinned against God, special relationship to God or some other entity. That's sort of idea. So. And of course, you can have more than one delusion. And these are beliefs, okay? So as opposed to hallucinations, that's probably a pretty good point to make, actually, to elaborate on that. Hallucinations are a sensory modality issue. Delusions are a belief system. Okay? They're a belief system. In addition to the ones that are listed in the textbook, thought insertion, thought withdrawal, and delusions of control. So thought withdrawal is someone can take your thoughts just literally. And it's just like they can rip them out of your head. People have that feeling. And thought insertion was where people can think they think you can put thoughts right into their mind. And it's directly into your mind. I mean, I can put thoughts into your mind easy. Like now you're thinking of a horse. Ta-da! You're thinking of a horse, and now you're thinking of an apple on top of the horse's head. That's inserting thoughts, but this is more directly. This is inserting thoughts without my screwing with you. And delusions of control. The FBI or the CIA or church, again, it's usually big organizations like that that'll have control. I've not worked with any Muslim people with psychoses, with schizophrenia, but I have Jewish people. And it's interesting with the religious side that the Jewish people, and actually Native American culture too, thinking back, Christians will have some modality with Jesus, but the Jews will have with more like with Moses, more of a Jewish one, and have Indian guy had with the, I think it was a peyote chief, if I remember correctly. And so the religious side can be cultural related, which is kind of interesting.
So I have a question on that. How would you separate that from just like normal, quote unquote religious belief?
Yeah, it's that's a good question, and sometimes it gets a little bit tough to do. Usually, though, it's they think there are Elijah. Okay, they think they are the creator, or or they are Jesus, or Jesus is on the inside of them. But you're right, it can be kind of tricky. The other thing, though, is it doesn't occur by itself. Okay, they usually don't have religious ideas just by itself. They'll also have hallucinations, maybe, and certainly by definition, the negative symptoms. So it's more the overall picture and not just religious beliefs. Does that help your question?
Yeah, that does. Thank you.
Okay. You're welcome. So in the negative one, diminished emotional expression. So positive, this is where people often get kind of confused. The psychotic dimensions are also called positive symptoms, but the reason they're called that is, in your textbook actually just calls them psychotic symptoms, which is probably better than positive symptoms, but you'll see positive symptoms in other places. It's positive as in addition. It's things that are there that should not be, like hallucinations and delusions. So negative is like subtraction. It's things that should be there but are not. So diminished emotional expression, kind of a flat affect. Well, maybe I'll do this later. Sort of a flat affect. Intonation of speech. They don't have as much prosody, where they might have. Well, I think it demonstrated some of this earlier, right? Where I had people ask me what brings me to the clinic. I'd say a bus. And you might have just really slow speech. Doesn't work as well in this modality, does it? Avolition. They don't have goal-directed behavior. They have to be. Your textbook has seem inert and unmotivated, and that's actually a key point, that they seem unmotivated. That's not the case. Unmotivation implies some kind of a, more of a personality problem, something like that. It's a symptom. It's not a defect. Well, let's see if I can express this correctly. Avolition is a symptom of the illness, not some trait of their personality. And that's important to know, because sometimes when you're working with folks, it gets frustrating. It's like, well, come on, do this. Why aren't you motivated? Well, they're not motivated because they have avolition as part of the symptom. Alogia, diminished amount of spontaneous speech. So just very, very, very little spontaneous speech. So logia, that's logia is for words, right? Logic, logia, logos. In the beginning was the word logos, and alogia is no. So no volition, no speech. Hedonism is pleasure, so no pleasure, and asociality, no sociality. Yeah, they just don't have. They just describe themselves as feeling emotionally empty, don't enjoy things, and sometimes they just don't really care. They just don't. So this is the negative dimension. We've got the positive or psychotic dimension and the negative dimension. Then finally, disorganized. So derailment of speech. where you just be talking along, and as you're talking, it seems like you have a logical way of expressing things, but then the boats are out there, and you start talking about the boats in the water. With the boats in the water, we kind of come around through the boats with the submarines, and the submarines will come around. Loose associations is where you in tangential ideation, where those are very, very similar. We have looseness, where you kind of become unraveled, just like a shoestring, and shoestrings become unraveled, then you fall over because your feet are and no longer have shoes on them, and it's hard to walk on the ice. That's the idea. How'd I do? Did that work? I'm sort of experimenting with some of this this disorganal, and then incoherent. Whether they just don't make any sense. Sometimes they just don't make sense. They just kind of going over. So silly. They're just kind of goofy, agitated. Negativism, they're resistant to instructions. Mutism, they just don't say anything in stupor. They're just a bizarre posture. I'm gonna try. Maybe I will turn my camera on, even though it looks funny. Actually, I'm gonna. Yeah, let me see something here. Hold on, let me get rid of my background. So, bizarre posture might just be something like, you'll see people, like in some of the mental health conferences and whatnot. People with schizophrenia might go there, and you'll just be standing, going, start screaming at people, screaming, and then it'll stop, and they'll kind of go back and forth like that.
So, like gangsters, would you consider them with schizophrenia, like the ones with the gang signs and?
No, well, they have gangsters, like in they have their own signs. Yeah, no, those ones. That's a language.
Oh.
Yeah, could have to be like yo or something. I don't know.
I also think they were like mentally something wrong with them or something.
For gangsters, no, not really. I mean, they're gangsters, so that's probably not the best of things. But no, they wouldn't have anything wrong with them, so to speak.
Oh, okay. So just being ignorant.
Yeah, that's okay. No, it's don't worry about that sort of stuff. Being quote unquote ignorant, because you're not. You don't know this material, and that's why you're here. I really encourage students to ask questions.
No, but not me. I was making fun of like other people.
Okay, good. Okay, that's okay. But you'll like occasionally you'll see folks on the street with schizophrenia, and you can, once you learn what it is, you can sort of tell. Frankly, it's just probably a little bit more. That might be a little bit of an overstatement, but you kind of can, because they act like they have schizophrenia. They do this disorganized stuff. They may be talking to themselves. They might be kind of rocking. And then there's a fellow in town. He must have got either into treatment or something, but at Malfunction Junction, this is like a year ago or something now, where he would run out between cars at Malfunction Junction, which is not a smart thing to do. And just start yelling strange things into the window. And could he be some other form of psychosis? Yeah, he could be, but certainly it's very likely to have schizophrenia. And here's here's even more catatonia. It's pretty interesting, where they just immobile, mute. They just kind of will sit there. And conversely, catatonic excitement is they have uncontrolled and aimless motor activity. They're just kind of always going, but it doesn't make any sense. Stereotyping, they'll have like, well, the one, look around downtown, or if you go to a larger city, just kind of pay attention to that, because you'll see people doing this. The mannerisms, odd appearance, like grimacing, stuff like that. Oh, that could be tardive dyskinesia. Echopraxia, I guess it's actually pronounced. That's speech that they will always just echo you. So I need someone to start talking to me to demonstrate that.
Okay, I guess I'll go.
Okay, I guess I'll go.
How y'all doing today?
Thanks.
I had peaches for breakfast this morning.
I had peaches for
and
breakfast
It's really
this morning.
smoky outside
It's pretty
today.
smoky outside today.
Now I'm going to a lecture.
I'm going to a lecture.
Do you want me to keep going or do I?
No, that's probably enough.
Okay.
Uh,
Dr.
It's-
Iman, I have a question about echopraxia.
sure.
Is that something that can occur in people without a psychotic disorder as well?
Yeah, it is.
Okay.
Yeah, and yeah, it is actually. Yeah. It's also not just speech, though. I mean, the textbook talks about it with the movements and whatnot, but it's also speech. So, yeah, it is. In fact, I've known people who do that, and it's really kind of strange, but they'll do that just in general. But again, with something like schizophrenia, it has to be the whole shebang, as it were. You have to have more than just one or two symptoms. Automatic obedience. You ask them to do something, they just do it, right away. Go sweep the floor. They stand up, grab a broom, start sweeping with no real response. So I think you can probably get in the picture here. Yeah. So a few other things. Disorganized behavior. I think we already talked about that some, so we don't need to add it back in. Or negativism, actually. That's another one I probably should add. Negativism. Patient refuses to cooperate with simple requests for no apparent reason. They just don't. And that gets kind of mixed up, I think, with avolition. I think those are splitting hairs sometimes, and it's hard to know which is which. So you might ask somebody to, let's go play pool. Let's go play pool, and they'll just sort of sit there and look at you and not do anything. Now, is that negativism or avolition? And it's kind of hard to sometimes separate those out, and really, you really don't have to, for the most part. And here's some other just interesting things, interesting symptoms. They have many lack in insight, of course. They don't realize that they're psychotic. Deficits in processing sensory stimuli. They can't process things as well. Most of us can shut out the second stimuli, right? That might have, like with evoke potentials. If we have two sounds come in, we usually can filter them, kind of focus on one and not the other. They can't. They aren't able to do so. And this is kind of interesting. This one here, the hyponatremia polydipsia. This can be a real big problem for people in schizophrenia. What happens is they'll drink a lot of fluids, polydipsia, like a lot of fluids, gallons in like a half hour or something, and their sodium level, natremia, hypo is below, like hypodermic is below your dermis. So low sodium, lots of drinking. And it can be quite the problem because hyponatremia, that's not good. They can give cardiac problems, and they get delirious and all kinds of things like that. Yeah. So let's see, soft neurological signs, also kind of an interesting thing. Let's see if we have some of that. Yeah. Poor coordination and balance. Stereognosis. That's where they just they can't understand writing. Graphesthesia is they can feel writing. Proprioception is sort of abnormal. They kind of just fall over. So it's all these sort of soft neurological signs. What I think this is the main point I want from this this slide is to really emphasize how schizophrenia it's really more than a brain disorder. I mean, it has all this other sort of, well, it's more than a psychiatric disorder. It has all these other more neurological symptoms than just the psychotic symptoms. It's really quite profound. The hyponatremia and polydipsia, by the way, it's not just because they're psychotic and they drink water. They actually have an abnormality in the hypothalamic renal regulation of fluid intake, because your hypothalamus basically controls everything, but including your sodium level and your fluid intake. So it's actually an abnormality within the hypothalamus. One thing I could probably do, actually, I might even do it here while we're thinking about it. I can take pictures of some of the more important aspects of the textbook and send those. I'll post those. So if people don't have the Let's see if I can do this without getting a shadow in there. I can't. Well, I'll do it later. So I'm trying to do two things at once here and it's not working. But I'll take pictures of some of these charts and tables and whatnot and post those. That'll be helpful. That'll things that I don't have on the PowerPoint. I'll just post. Again, poor insight in the illness, substance anxiety, depersonalization. So they might be afraid of some particular thing. And now is phobia against spiders, say, is that just one of their delusions, or is it something set off by itself as a simple phobia? Most people would say, let's just put it under delusion, as opposed to giving them a second diagnosis. Depersonalization. This is a feeling that you're just not there. You're kind of in the world, but not part of the world. That sort of thing. So that's the depersonalization. A small subset has violent behavior, but a small subset does have violent behavior. Now, this is just true. Oops, I think I lost my teams over here. Too many things going on. This is try to. I got this. My apologies here, folks. Come on. Here. As I went to my camera on my phone to take pictures, it then kicked me off Teams, so I had to come back for that. So where was I? Subset with violent behavior. And in particular, if they have a delusion toward one person, right? Somebody in particular, they can have violent behavior. And nicotine. Nicotine. About 85% smoke. I think it's probably higher than that, but that's more impressionistic. But they really, they smoke a lot. It probably helps them as far as coping with the symptoms. The nicotine itself probably helps them with their overall illness, and not just be an addiction per se. So about 1% of the population worldwide has schizophrenia. Worldwide, it's not particular for any ethnicity, not particular for any nationality, nothing like that. It's about a 1% worldwide. Very costly to society because they get it young, right? They're usually people will have this fairly young, late 20s or late teens, early 20s, and they won't. I mean, they live for quite a few years, decades. They die earlier. They have a shorter lifespan, but it costs society a lot because they're not able to work and they take a lot of care. They have a high rate of suicide, somewhat sadly. In particular, if they have insight into their disorder, that they have an insight that they have this very major mental illness. Actually, one thing that you'll see, here's a precautionary thing for you all, kind of a clinical tip. When people get better, okay, if they have a psychiatric illness, and in particular, it's more like schizoaffective disorder, which we'll get to. When people get better, they oftentimes can become suicidal then. Because they have an insight that, oh my God, I've been ill for this long. How can I, what am I going to do? How did I ruined my life here? So that's one of the things. This idea of downward drift theory, social functioning. This is where I don't know. It's worth knowing, but basically what the idea is because you can't function, and you have a downward drift in your overall course of life. Do people care if my my video is on or not, or does it really matter?
Doesn't matter.
Okay. Yeah, I didn't think it did, but thought I'd ask. So again, the positive symptoms, I'm going to elaborate a little bit more on that. So it's too much dopamine in the sensory areas, in particular, the mesolimbic, right? So we have the 4 dopamine pathways again, mesolimbic. And this is where you have all the hallucinations and whatnot. But the main point here, I kept this one in from previous slides, as opposed to getting rid of it, is to emphasize the dopamine in the mesolimbic cortex. In the mesocortical, too little in the frontal lobes, again, sort of re-emphasizing some of those, the 4 motor pathways, or 4 dopamine pathways, is too little in the prefrontal cortex. Okay, so that's a mesocortical. In some of these, catatonia probably is within the motor cortex, so the nigrostriatal. Okay, the nigrostriatal is involved with those, with some of the psychomotor symptoms. So I revisit those for you to once again bring up those the 4 dopamine pathways. Thank you, Lucinda. It's fine. Gotta remember those 4 dopamine pathways: mesocortical, mesolimbic, nigrostriatal, and hypothalamic pituitary. So another table. I'll take pictures of all these and post them. I think I can do that without having to be too worried about copyright infringement. So I'll do that. So prodromal phase. This is interesting. They tend to have a phase before they have the major symptoms. Prodromal, mid to late teens, a little bit blunted affect, a little bit social function withdrawal. So it's not necessarily noticeable, but it's there. Okay? It's just there. It's kind of a prodrome. There's some studies actually that look at very early on childhood, like 5, 6, 7, 8 years old, where they notice that it's actually kind of a cool study. I like bringing it up because it's just a cool study. They had old family movies the various children a family would have, and they'd have both professionals and lay people sort of pick which one ended up having schizophrenia, and they could pick it most all the time, pick the right kid, because it just was not quite as coordinated, just a little bit withdrawn, those sort of things, which you wouldn't really notice unless you were looking for it. So that's something you can see. Then the active phase, late teens through early 30s. This is where they're having active psychoses. They're looking at hallucinations, relapses of the hallucinations, etc. And then the residual. This is where they're older. The residual phase is they're older, usually in their 40s, 50s, less positive symptoms, but still with quite a few negative symptoms.
So you said the predominal phase, that's like infancy or?
Prodromal. Not so much infancy, more like early teens, but some studies have noticed it in like more like late childhood, right? Like 10, 8 to 10.
Oh, okay, thank you.
But not infancy. In infancy, no.
Okay, makes sense. Thank you.
You're welcome. This is kind of a rough thing. 2 years before symptoms become troubling enough to see a psychiatrist, and that's not good. that's not good. We'll get to treatment here, if not today, then on Thursday. But we're doing pretty good. So there's good prognosis and poor prognosis. Against table 5.5, which I'll take a picture of. But the onset, if it's a quick onset, acute, that's better. Insidious is worse, poor onset. If the prodrome is short, that's better. And if it's since childhood, that's worse, et cetera, et cetera. So with mood symptoms, it's better. Poor outcome, it's worse. What's some other ones? Females tend to do better than males. Psychosexual functioning, if it's poor, that's worse, etc. So there's a lot of things that can be for better or worse outcome with schizophrenia. Interestingly enough, the long-term studies show that they're more hopeful, although it really kind of depends. It's a range of an illness. This is one thing to keep in mind is there's different levels of severity. Okay. Different levels of severity with people with schizophrenia. So some will have a really difficult course of the illness, and others will do better. Apparently, in less developed countries, they do okay. The idea is that the families take care of them more. And that's the idea. You used to see this here. Probably not as much now that people are getting a better idea of what these illnesses are. People would be kind of ashamed, right? And it was usually a sister taking care of a sibling and just kind of keeping them in the house. making sure they had enough cigarettes and food, that they were contained. They didn't run around, shouting psychotic things. And the story would happen is the sister or other sibling would die, and then the person who had schizophrenia would be brought to attention, brought to clinical attention. So it's really interesting. You'd have people who had schizophrenia for like 30 years with no treatment. It's really it sucks for them, but really, really interesting for people who don't have it, I guess you could say. Pretty large differential diagnoses. Another table I'll copy for you. But delirium, drugs, psychoses due to medical conditions. Now, there's the various things, various tumors. I had a guy who had a kid actually had a brain tumor and presented with auditory hallucinations. So I got an MRI, and sure enough, I found the brain tumor and sent him to a neurosurgeon, and he hasn't had hallucinations since. Various other types of psychiatric illnesses, bipolar disorder, major depression disorder, those can all have hallucinations and delusions, so they'll kind of look like schizophrenia maybe. Drugs, of course, methamphetamine, sort of the main one. Actually, it's kind of one of these concerning things that probably needs more research. I don't know if there's much on it, but there's people who with schizophrenia who are doing methamphetamine. People have coined the term methaphrenia, and that's really a bad idea. There's bad ideas, and then there's really bad ideas because, well, meth acts on the dopamine system. So they're cranking up the dopamine system, and their dopamine system is bad enough as it is. So, yeah, the sort of the anecdotal evidence of taking care of those folks is really not so good as far as prognosis. Tertiary syphilis. Primary syphilis is the genitals. Secondary is sort of spread around the body a bit more, and tertiary is in the central nervous system. Tertiary syphilis, you can have psychotic symptoms. It's pretty cool because you can treat it with the IV, well, actually intracecal, so antibiotics within the central, the cerebrospinal fluid. They put it in the bottom of the spinal cord there, and it goes throughout the brain and treats tertiary syphilis, and you cure their psychotic illness, which is pretty cool. There's other medical illnesses, again, listed on this table that I'll take a picture of and post. Temporal lobe epilepsy is sort of wild. So the temporal lobe epilepsy, they'll look like they're having hallucinations. Well, they are, but it's due to the epilepsy. Vitamin deficiency, autoimmune disorder, lupus. Actually, I don't think we've talked about lupus much, have we? There's a running joke from this class that we haven't talked about. Yeah, I'm sorry. I'll talk to our financial office to see if you can get a partial refund of your tuition. Differential diagnosis, although they're differential diagnoses, we're just now kind of bringing up, so maybe it won't be that much of a refund. It's not going to be any. I have no ability to make that call. But lupus. Systemic lupus erythematosus. If you ever watched the movie or the TV show House MD, this is a great show. And lupus is always in the differential diagnoses because it always is in the differential diagnoses. It can look like a lot of different things. So a running joke in this class is when you have differential diagnoses, always mention lupus. The reason I have that is not just that it's funny, but, well, 2, it actually can happen. It actually does present this way. And 3, you want to make sure you think of medical illnesses, right? Medical illnesses that can cause any of this stuff that we're going through. So that you're going to cover in the course. So it's so lupus is kind of a running joke with points. Autism can look like it too, especially with the negative symptoms. But as we covered last week, autism is its own thing, very much so. So what causes it? All kinds of stuff. We don't really know, but we're getting actually a pretty good idea. Probably there's a genetic predisposition, okay? But then that requires other things, in order for it to be expressed. A lot of stuff has been tied to it: brain injury, poor nutrition while pregnant, substance use. These all correlate with schizophrenia. Of course, it's correlation, and we're not going to do some kind of experiment on pregnant women to see if we can make their kids have schizophrenia, but there is a correlation there.
So I have a question on that. My wife is currently pregnant.
Okay.
And she craves absolute dog shit all the time. And
I hope you're not mean literal dog shit.
no, not literal dog shit, but like, I mean, just very non-nutritional foods. But she takes her prenatal vitamins and all that kind of stuff. Is that enough, or like, I mean, what does it mean when it says poor nutrition? Is it just like
starving?
Oh, okay. So just not enough nutrition, essentially.
Right.
Okay. Okay, that makes sense. We're good. I'm in the clear.
And actually, having pica, that's actually what wanting to eat non-food items, including dog shit, I suppose, but hopefully not. Sorry, I kind of knew that was being figurative, but I just had to ask that anyway. Pica during pregnancy is not rare. People want to eat chalk. They'll have strange desires for pickles and ice cream or something. So that's actually not uncommon.
During my pregnancy, I craved like the smell of like the aromatherapy of gasoline or rubbing alcohol or.
Yeah. So
I stayed away from it, but like my body was drawn to like the stronger smells like that.
No, like here we go. Yeah, I mean, you have another thing growing inside you. So Carly, I ate ice for every meal while pregnant. LOL, like 8 times a day. Yeah, ice. And it's just one of those things. So genetics, it's 46% for identical twins. I usually just say 50 because it's easier to remember 50 than it is 46. But so 40%, if you have identical twins, one has it 46% of the time, the other one will as well. If both parents have it, then it's another 46%. Fraternal twins for 17, so it goes higher. 10% for first degree relatives. So there's clearly a genetic component to it, obviously. And this is kind of a cool thing. When we cover a personality disorder, schizoid personality disorder and schizotypal personality disorder, they're like, schizoid is sort of like the negative symptoms of schizophrenia, and schizotypal are sort of like the positive ones, just not as bad, right? They're just not as prominent, if you will, not as severe. Bad is probably the wrong word, severe. So they're probably like on a range of presentation of schizophrenia, these personality disorders, because there's more in their family than you would think from just the general population. And there's all kinds of stuff. The etiology has looked at all kinds of things. This is listed in your text, so I don't need to copy this page. So it's all here. But numerous attempts have been made to identify genes using linkage and candidate gene methods. This is what they talk about in the books. Obtaining robust and consistent results has been difficult. Really, they haven't been able to do that, frankly. They've not been able to have consistent results in replicating studies and all that kind of stuff. So they can find all these proteins, the genes for these things, and this is all listed. Dystrobrevin binding protein dysbindin, catechol O methyltransferase, disrupted in schizophrenia 1. There's just kind of a funny name for someone with schizophrenia. D-amino acid oxidase activator, metabotropic glutamate receptor 3, etc. You can read those. So there are data, right? There are data that show these abnormalities. Again, how much can we really trust those? Well, we can. And the cool thing is that these are giving us images, giving us clues as to where they continue to look. So that's pretty cool. So COMT, again, we'll just call it COMT instead of catechol O methyltransferase. That's involved in dopamine production. Okay. And these other ones are glutamatergic neurotransmission. So glutamate, there's various neurotransmitters. Glutamate is one of them. Dopamine is another one. So there's all kinds of them. So dopamine, glutamate. And really, if you look at them here, neurotransmitter systems implicated in schizophrenia, there's all kinds of them. neuropeptides, cholecystokinin over here, norepinephrine, acetylcholine, dopamine, glutamate, GABA. All these are involved with schizophrenia. So we tend to have the dopamine hypotheses, that meaning that we think dopamine is the main neurotransmitter, and it's certainly one of the major ones. But if it's the one, probably not actually. So yeah, it's a really complex disorder. It's a really complex disorder. In case you weren't thinking about it, just in case, here we are to the 4 dopamine pathways again. So nigrostriatal. So where's the substantia nigra? Right here to the stria, basal ganglia. Okay. Nigrostriatal, mesolimbic, and mesocortical. Okay, so those two are the other ones as well. Mesolimbic, prefrontal cortex, mesocortical, and the hypothalamic to the tuberoinfundibular system, but it's easy to say hypothalamus to pituitary. That's kind of easier to say that. Right there. Again, those are key. Enlargement of lateral ventricles. It's probably considered, people consider it now a neurodevelopmental degenerative disorder. So as the brain develops, it degenerates. Right? So this is here showing some functioning. This is a lack of functioning in the prefrontal cortex. That's the hypofrontality. Okay, so hypofunctioning is not so much just the negative symptoms. And here shows the enlarged ventricles. Enlarged ventricles for some with schizophrenia. So it is a degenerative disease. In fact, the more symptoms, the more episodes of psychosis a person has, the more degenerative it is. So that's like a key point. And we'll get to that when we start talking about treatment. We're doing fine. Large sulcus. Okay, that goes back to here. Remember the difference between sulci and the gyri? Gyri is the brain, and sulci is the space between the brain. So here you can kind of see the black streaks are the sulci, space between the brain tissue, and they're bigger. I mean, you can really appreciate that for on this double scan here. So the more enlargement, okay, the more associated with poor premorbid function, more negative symptoms, worse treatment response, and cognitive impairment. So it's also, it used to be called dementia praecox. That was the first term for it, because it does have a dementing sort of process as far as the cognitive impairment is concerned. And so that's the other, some of the other neurological symptoms of it is the cognitive ones. And here's my claim to fame. Oop, Michelle, you're requesting control.
No, I accidentally hit that button. I'm trying to do something else over here.
Okay. Yeah, I'm going to deny you control.
Thank you.
Okay. So, viral exposure. Yeah, this is a pretty interesting thing. It could be some kind of viral infections. Well, there are more people with schizophrenia born in the spring. So the idea is that mothers have a cold or influenza or whatever, where during the winter, during the second trimester, and then the babies are born in the spring. Some Scandinavian studies where years that there was a high rate of influenza, those cohorts had a higher rate of schizophrenia. And this is my claim to fame. Hopefully I'll have more claims to fame coming up. One of them is microglia. This is a link to my article if you want to help out my narcissism. So microglia are we covered them a couple of weeks ago, right? They're the kind of the immune system cell of the brain. They go around. They actually are derived from white blood cells. They go around and take care of damaged neurons, infections, including like viral infections. And then the idea is they cross-react and start attacking the brain excessively. And they have more pruning, more abnormalities within the neurotransmitter system, and inflammation. Okay, the schizophrenia is being looked at as an inflammatory illness, of the brain. So that's pretty interesting. again, when we get to treatment, and we can reiterate this because it's just cool. Minocycline. Minocycline is an antibiotic similar to tetracycline, which you probably have heard of tetracycline. It inhibits microglia activity. When people get minocycline early in the course of the illness, they get better. It works because it's suppressing microglia activity. And inflammation, people can get on Celebrex, which is a type of anti-inflammatory, non-steroidal anti-inflammatory, and it too, early on in the course of the illness, shows improvement of symptoms. So that's pretty cool, right? That's pretty cool that we're giving some of these treatments that are you have to be pretty early on, but maybe that'd be a cool thing to have happen. I tell you what, it's a pretty devastating disease. I keep these in there. This is left over from previous books, right? This is where it really keeps us in here to just be slightly irritated. So, but you'll hear this, and just don't believe it. So, blame mothers for everything is sarcastic. Okay? That's sarcasm. So sometimes students will think that I'm not being sarcastic, but I am. But you'll hear the Freudian psychoanalytical theories of schizophrenia, that somehow it's this weird, repressed processing of their ego super dynamics or whatever. It's just simply not true. It's just ridiculous to even think that. So in behavioral, they literally would have these in previous textbooks, which is why I just got kind of irritated with the textbooks, that somehow operantly and classically condition these hallucinations. It's like, no, you do not. You don't. You might be able to operantly condition the way people express those, the conditions that they express them. In fact, that's part of the treatment. But no. Yeah, they're not cognitive distortions either, like we see in depression and anxiety. You don't have some kind of distortions on self and future that lead you to have schizophrenia. You can have it for understanding the illness, but not the cause. And people use cognitive therapy to have people learn how to deal with the hallucinations, actually. And then the social labeling. That's, you get called schizophrenic. Someone says you have schizophrenia, therefore people treat you like you have schizophrenia. Therefore, you become a person with schizophrenia, but mainly just from social labeling. Also, I'd say no. That said, stigma against schizophrenia or being afraid of people with schizophrenia, that's a social process. Okay, so that will worsen the course of the illness. But as far as like causing it, nobody really thinks that anymore. It's just simply not true. So blaming mothers for everything is sarcastic. So there's other ones that are kind of in there, and we don't really know this too much, but again, I keep them in there for discussion's sakes. Maybe hiring African Americans and Hispanics. Again, this is from previous textbooks. I don't think that's true anymore. In fact, I probably should look that up on PubMed. I'll check that out. Might be socioeconomic status, but that might be when you get schizophrenia, your socioeconomic status tends to drop off. Family dysfunctioning, though, is definitely one. Expressed emotions, it's a tense environment. Okay, people are out of control, yelling at each other. In double bind, where you can't do anything right sort of idea. You do this, you're wrong. You do that, you're wrong. So family dysfunctioning definitely contributes to the course of the illness. But again, not probably, not. So that's when you write about the social cultural, write about the family dysfunction worsening the course of the illness, but not causing it, if that makes sense.
Do you think, because, with what you mentioned about pregnancy, poverty would have something to do with that? I mean, because African Americans and Hispanics are disproportionately affected by systemic poverty, therefore leading to malnutrition, the things that you had highlighted.
That could be. Yeah, maybe socioeconomic status and poverty. Huh. I don't think, though, and I need to have someone. I need to have my PubMed students. Sometimes in classroom, students will be on their computer, and I will voluntold them was it called Voluntel? Voluntel them to go on PubMed and do a search for ethnicity and schizophrenia, socioeconomic status and schizophrenia, just see what you come up with. So if anybody wants to volunteer that, that's great. Oh, actually, that reminds me. Oh, I should have put this in. We did find some, the movie, some links for those, the town that acquired Tourette's. That was great. Thanks, Annalise, for finding that. But it's really interesting. So maybe if kind of see where we go here. If we get a natural pause, I'll pull that up because I'm sure it's staph or strep infection. It just seems like a strep infection, and nobody looked at that as far as I can tell from the clips. So let's actually, that's not a bad place. So I'm going to stop here. Let's see, how we got here, 15 minutes, right? What time is it? 11 o'clock. Let's see. Time out, please. I'm going to stop sharing. Stop recording.